Hi everyone, my name is Maria and I have been working alongside my supervisors Dr. Eliane Ratcliffe and Dr. Gregorio Zuniga to complete a systematic review investigating the efficacy of medicinal cannabis in treating gastrointestinal ailments in pediatric populations. In other words, we're trying to assess whether medicinal cannabis is truly an effective treatment in pediatric populations for GI-related issues. Before I begin to describe our research, I'd like to share some background information as to how cannabis interacts with our brain and bodies, and why it is a proposed medication for gastrointestinal issues. The main regulatory system which cannabis interacts with is called the endocannabinoid system. The system is already present within our bodies and is composed of endocannabinoid receptors, mainly CB1 and CB2, and is also composed of endogenous cannabinoid ligands, called 2-HG and anandamide. This signaling system is responsible for regulating several processes, such as pain, memory, learning, and sleep. CB1 receptors are located in the brain and throughout the body, while CB2 receptors are more localized to the immune system and gastrointestinal system. Their abundance within the gastrointestinal system has implicated the endocannabinoid system and the regulation of GI function, such as GI motility, secretions, and hypersensitivity. It has been proposed that the underlying causes of gastrointestinal diseases, such as inflammatory bowel disease, may involve dysfunction within the endocannabinoid system. This theory has been supported by the evidence that there is slightly increased presence of CB2 receptors within IBD tissues. Medicinal cannabis is the prescribed form of cannabis originating from the cannabis plant. There are more than 60 active compounds within cannabis. However, the most notable compounds with therapeutic uses are cannabidiol, or CBD, and tetrahydrocannabinol, or THC. These are classified as exogenous cannabinoid ligands, capable of interacting with and modulating the functioning of the endocannabinoid system. THC is a partial agonist of CB1 and CB2 receptors, whereas CBD exerts its effects by affecting the binding of THC and other endogenous cannabinoid ligands. CBD is also able to reduce the psychotropic effects of THC. Based on these interactions, it has been suggested that endocannabinoid compounds, such as those in cannabis, are able to restore normal endocannabinoid functioning. This has caused cannabis to be prescribed for a variety of ailments, such as inflammatory bowel disease, chemotherapy-induced nausea, neuropathic pain, and many others. The prescription of medicinal cannabis in both adults and pediatrics have been on the rise. And as THC in particular is linked to risks such as neurocognitive impairments, developmental delays, dependence, and even psychosis, it is recommended by guidelines to limit the prescription of medicinal cannabis among young children. However, in the cases when traditional medications prove to be ineffective, alternative medications, such as cannabis, will be sought after. Thus, our study wanted to ask the question if cannabinoids are truly an effective treatment for GI-related symptoms in pediatric patients. To investigate this, our systematic review obeyed the following methodology. Our systematic review is the product of an initial scoping review, which investigated the overall impacts of cannabinoids on the GI system of pediatric patients. We completed a formal database search through the McMaster librarian with keywords relating to cannabis, the GI system, and pediatrics, which provided us 7,303 hits in total. After the removal of duplicates, we ended up with 5,080 papers, 446 of which underwent full-text extraction because they fit all of our inclusion criteria. These were then categorized based on the type of cannabinoid treatment, dose, length of treatment, and ages of patients. 5 papers in total fit all of our inclusion criteria and then went on to qualitative analysis. These 5 studies consisted of 3 double-blind crossover studies, 1 retrospective cohort study, and 1 randomized controlled intervention study. In addition, the 3 double-blind crossover studies investigated the ability of cannabis, particularly nabilone and THC, in treating chemotherapy-induced nausea. The retrospective cohort study utilized mixed composition cannabis oils to treat the symptoms of severe complex motor disorders. And lastly, the randomized controlled intervention study described the treatment of inflammatory bowel disease symptoms through the use of mixed composition cannabis oils. From these studies, we identified 6 GI-related symptoms which were attempted to be treated by cannabis. These included nausea, vomiting, abdominal pain, constipation, weight, and appetite. Here we have summarized the main findings regarding the efficacy of cannabis in treating GI symptoms. The 6 main GI outcomes can be seen on the left column, and on the top row there are the 3 main areas of focus: chemotherapy-induced nausea, which we have denoted here as C nausea, inflammatory bowel disease, which is also known as IBD, and severe complex motor disorders, which we have denoted here as motor. Additionally, we have used 3 different colors to indicate the success of treatment. Yellow indicates no change or that the cannabis was unsuccessful in treating that symptom. Green indicates that the symptom decreased, and orange indicates that there was an increase in that symptom. So I will walk you from top to bottom in regards to each of the symptoms. In regards to nausea and vomiting, both of these symptoms were significantly decreased within chemotherapy-induced nausea patients with the use of THC and nabilone. Also for reference, nabilone is a synthetic analog of THC. However, within IBD, cannabis oils showed to produce more mixed results with no clear changes as a result of treatment. In terms of weight change, the study investigating the treatment of IBD symptoms state that the symptom does not change as a result of cannabis treatment. Constipation was addressed as a symptom within the severe complex motor disorder study, which stated that only the groups receiving cannabis oils with high CBD concentrations reported a significant decrease in their constipation. Abdominal pain was briefly mentioned within the study attempting to treat IBD symptoms. Within the study, it was stated around 50% of patients utilized cannabis to treat their abdominal pain. Appetite was reported to improve significantly within severe complex motor disorder treatment. However, within the study investigating chemotherapy-induced nausea, there did not seem to be any changes within chemotherapy-induced anorexia. The study focusing on the treatment of IBD symptoms also had much more mixed results, with no clear betterment or worsening of appetite. The findings we've seen can be explained by up-to-date research within the field. However, these may relate more to adult mechanisms and might not be entirely pediatric specific. However, there's little understanding of the different mechanisms between adult and pediatric populations in regards to cannabis use. In terms of nausea and vomiting, it has been found that regions of the brain involved in emesis, or vomiting, such as the dorsal vagal complex, contain CB1 receptors as well as endogenous cannabinoids. Agonism of the CB1 receptor has been shown to suppress nausea, and as THC is a CB1 agonist, this may explain the reduction of nausea and vomiting seen in the chemotherapy-induced nausea studies. The mixed results observed in the IBD study may potentially be a result of using mixed composition cannabis oils rather than pure THC. With regards to abdominal pain, CB2 receptors are thought to play a role with inflammation, and the increased presence of these receptors in the context of inflammatory bowel disease may contribute to the development of commonly experienced IBD symptoms. CBD has demonstrated anti-inflammatory properties, such as being able to decrease neutrophil movement and growth. This may justify the finding that nearly half of patients within the study used cannabis oils containing CBD to treat their abdominal pain. Cannabis has demonstrated the ability to stimulate the orosensory pathway, which ultimately leads to eating behaviors. It has been reported to be able to treat anorexia nervosa. However, findings within chemotherapy-induced nausea studies demonstrate otherwise. The mechanisms underlying this are still fairly unknown. Cannabinoids have been proposed to regulate and maintain weight by preventing metabolic alterations, and this is in line with the findings within the IBD study, which said that there were no weight changes observed. However, even these mechanisms require more research to fully understand. CBD has shown to increase gut motility and regulate gut functioning. However, in contrast, THC has demonstrated inhibition of gut motility and secretions. These contrasting properties may explain why only high CBD content oils were effective in decreasing constipation. Overall, the included studies have demonstrated that the efficacy of cannabis in treating these symptoms is specific to the patient subpopulation it is being used within. Limitations of this study include the fact that some of the studies did not include the composition of the cannabis products being used. In addition, specific patient subpopulations may be using different concomitant medications, which may impact the success of cannabinoid treatment. In addition, although some of the included studies were of fair quality, others were of low quality, and this indicates that there is a requirement for more research to understand the true efficacy of this medication within pediatrics.